Thanks to those of you who have just joined us. We're just going to give it a couple more minutes for more people to sign on before we get started. All right, I think we can get started. Welcome to What Black Women Need to Know About Endometrial Cancer. I'm Nefertari Moore, Uterine Program Coordinator at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast, ovarian, and uterine cancer for the last 44 years by offering the support of those who have been there. SHARE provides many services, including a helpline, support groups, and educational programs. All services are free of charge to participants. For more information, visit our website at sharecancersupport.org. All participants will be muted during the presentation. When Dr. Doll is finished presenting, we will begin the Q&A discussion. You are welcome to submit questions during the presentation through the question pane in the control panel on your screen. When asking questions, remember that the presenters are unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon. Now I'd like to introduce our speakers. Dr. Kemi Doll is a gynecologic oncologist and assistant professor in the Department of OBGYN and an adjunct assistant professor in the Department of Health Services in the School of Public Health. Her research centers on examining Black women, racial inequity, and the care of benign and malignant gynecologic disease in the U.S. She is the co-founder of ECANA, the Endometrial Cancer Action Network for African Americans, ECANAwomen.org, a community research partnership formed to improve survival among Black women with endometrial cancer. At this time, I'd like to introduce the doll.
Hi, thank you so much. I want to just double check that you can hear me okay?
Yes, I can.
Okay, great. Hello and welcome everybody who is joining us virtually. I want to give a really big thanks of gratitude to SHARE and specifically the uterine cancer team for inviting me to present about endometrial cancer in Black women today. I hope to cover several different topics and I'm excited to speak with you all in the Q&A as well. Let's see if I can, okay. So my goals for our time together today is one, to introduce endometrial cancer and the risks among Black women in particular, as I was asked to do by Cher, to discuss the experiences of Black women with endometrial cancer, and all of those things for the purpose of identifying actions to improve early detection among Black women with endometrial cancer. This talk, what Black women should know about endometrial cancer, really could span the whole day. And so I have tried to pick out some really salient topics to focus on and hopefully communicate some important information to you all. So first, we'll start with endometrial cancer and risks among Black women. My disclosure slide is that I have a perspective. So I am a gynecologic oncologist. I'm also a health services researcher, and I do research looking at healthcare systems and the people in them, so us, and community as well as providers, to understand how we deliver the best quality of care. But in addition to that, I also do read and practice race scholarship and really try to think about the ways in which race and racism in our society interacts with the healthcare system to produce some of the poor outcomes that we see among Black women, and that's certainly at play when we think about what's happening with Black women and endometrial cancer. So having said that, I actually, I like to begin to center endometrial cancer, not just as a topic of oncology of cancer, but also thinking about it as part of the spectrum of reproductive health. And when we look at Black women's reproductive health in the United States, what we see is that Black women have higher rates of fibroids, irregular cycles, when dealing with infertility, less likely to be successful, as well as higher rates of premenopausal hysterectomy, onto what I think everyone has much more awareness around now, which is poor outcomes in obstetrics with high rates of preterm labor, low birth weight infants, and maternal morbidity and mortality. And I offer through the reproductive course to later years also higher mortality in the gynecologic cancers, most notably in endometrial cancer. And I think it's important, and I'll come back to this, for us to think about what's happening with Black women and endometrial cancer in the context of what is going on with Black women in general and gynecologic health in the United States, which at this point is really unacceptable in terms of the quality. So endometrial cancer, as I think most of us know on this call, but I'll just say, is a cancer of the lining, inner lining of the uterus or the womb, distinct from cervical or ovarian cancer. There are approximately 63,000 cases per year in the United States, that's the estimate. And overall, the 5-year survival is over 81%, which is remarkably good for thinking about the whole spectrum of cancers. So in starting with how common is endometrial cancer, I want to start there. And again, since we're thinking specifically about Black women, that's where my focus is going to be. So this graph is a graph of the US endometrial cancer statistics by race and ethnicity, and incidence just means how common a cancer is. So these lines represent per group, a certain group of people, in this case, a group of 100,000 people, how common it is for there to be a diagnosis of endometrial cancer. And so this graph is divided by race because I think it's really important, one, to see that endometrial cancer cases are rising among all groups, and also to note that in the United States, it's actually both white and Black women that have higher rates of endometrial cancer than other groups of women in this country. I will note that the data that this comes from, there's been questions about the quality of the data with regard to Indigenous and Native women. So it might be that these statistics are not as accurate. However, for white and Black women, they are accurate. And I think the other thing to point out is that Black and white women essentially have the highest frequency of endometrial cancer in the United States, and it's about the same. So that means the burden or the likelihood of getting endometrial cancer is about the same between Black and white women in this country. Okay, so thinking about the statistics, about 63,000 women are diagnosed each year, And I think the take-home point for that I would like to share with this audience is that endometrial cancer is actually 4 times more common than cervix cancer. And though we have, I believe, a lot of awareness around cervix cancer and have you had your pap smear and everybody that's kind of in the community, in the vernacular, we don't have as much general conversation around endometrial cancer, the early signs, and early detection. There are estimated 725,000 endometrial cancer survivors in the United States, almost 250,000, and about 46,000 of these are estimated to be Black women. So there are many endometrial cancer survivors as well. And in statistical terms, I think a really kind of approachable way to think about endometrial cancer and how common it is that it affects about 1 in 37 Black women up through age 80 in the United States. So I don't think that is that uncommon. If we think about being in a room of 40 folks, you know, 1 in 37 women will be diagnosed at some point in her life. And just for comparison, for cervical cancer, it's actually 1 in 130, so less common. And as well for ovarian, it's 1 in 70. So in summary, so that's how common endometrial cancer is. So what's the prognosis of endometrial cancer, given the fact that it's fairly common? Well, as I stated before, overall, over 80% of women with endometrial cancer, they survive their diagnosis. We see that in the statistics from SEER, where the 5-year survival is about 82%. And if you just look at the middle of the graph, you can see compared to the new number of cases, which is the top line, the number of deaths is much, much lower. However, these statistics can mask what's going on among Black women. I put this in as a reminder that endometrial cancer is equally as common among white and Black women, but unfortunately the death rate is very different. So Black women have a 90% higher mortality than white women in the US from endometrial cancer. And what you see on this graph, the lines represent, the higher the line is, the more women with endometrial cancer are dying. And you can see here that compared to other groups, Black women by far are more likely to not survive their endometrial cancer diagnosis and have a much higher mortality. And just to put this into a little bit of context, this difference between what's happening among Black women and white women in the United States, it's actually a larger disparity. It's larger in size than the disparity that we see in breast cancer, in cervical cancer, or colon cancer. This is a slide essentially saying the same thing, where the Black-white mortality gap in endometrial cancer is actually one of the largest. This difference is one of the largest in all of cancer care in the United States. So again, when we come back to Black women's reproductive health, in some ways, those statistics I presented are fairly sobering. However, they also are fairly consistent with what's happening with Black women's reproductive health when we think of endometrial cancer being in this space. And that is why I come back to how we think about this problem. Because we have 2 options when we see that Black women are not doing well across the spectrum of reproduction. We can think that potentially there's something wrong with Black women themselves, or we could ask the question that potentially there's something wrong with the environment that Black women are in and the quality of care that Black women receive. And so this quote comes from Dr. Kindy's book, which is an excellent book about the history of racist ideas in America. And it offers this idea to start thinking that the only thing wrong with Black people is that we think there's something wrong with Black people. Because unfortunately, we have a long history in this country of attributing poor outcomes from Black people of certain diseases to racial biology as opposed to the environment and the quality of care that Black people receive. And I'm always asking the question of how is this at play? How is this happening within endometrial cancer? And how is this contributing to that graph and those excess deaths that I showed you? So in summary for this section, endometrial cancer is common. About 1 in 37 Black women will be diagnosed by age 80. And currently, Black women with endometrial cancer have the highest risk of not surviving their diagnosis. However, I want to say that this talk is not meant or designed to be all doom and gloom. I think it's important for us to truly understand the risk that as Black women that we have with endometrial cancer, but also to be talking actively about the interventions that we can take on our own behalf. So with that being said, I'd like to discuss the experiences of Black women with endometrial cancer based on recent research around what's going on with diagnosis and quality of care. So the journey of endometrial cancer diagnosis and treatment has many steps. It starts with symptoms of some kind, and in endometrial cancer, it is most commonly either abnormal, irregular bleeding cycles during reproductive years, or postmenopausal, or bleeding that starts to happen or start again after a woman has been through menopause. From there, women get a biopsy that confirms the endometrial cancer. They're referred to a specialist, usually a gynecologic oncologist. They have surgery, and then they have chemotherapy, radiation, other kind of treatment, or potentially they're finished at the time of surgery. I do want to say that at each one of these steps, there is opportunity and unfortunately evidence of differential treatment that Black women receive. However, for the focus of today's talk, I'm going to focus on early detection because I do believe that is where our community is most empowered to make a difference in our own outcomes. So, one early piece of research that I was involved with or led was trying to understand what would happen, what was creating or contributing to this difference in death rates between Black and white women with endometrial cancer. And so what we did is we took data that we have right now from women who've been diagnosed and treated with endometrial cancer in the National Cancer Registry called SEER. And we said, you know what, we're not going to change anything about the women, about their lives, about their underlying conditions, but we are going to assume that race would not play a role in when you get diagnosed, meaning you would get diagnosed at the same stage, and race would not play a role in whether or not you get surgery. And what we found in doing that work, and this was over 34,000 cases of endometrial cancer, is that 40% or almost half of this difference in mortality between Black and white women is actually attributed to the fact that Black women are diagnosed at more advanced stages and Black women are less likely to get surgery from endometrial cancer. Stage at diagnosis is critical. This is a major finding because stage at diagnosis is a very strong factor that determines likelihood of survival. That 80% survival in endometrial cancer is largely driven because the majority of women are diagnosed in early stages, where stage 1 endometrial cancer has very high survival. However, at nearly every age group and every type of endometrial cancer, not all, but nearly, Black women are diagnosed with more advanced stages. And this late stage at diagnosis, it's a major driver of the excess death among Black women. So going back to what's going on from symptoms to diagnosis, most women with endometrial cancer present with bleeding, and then there are many different pathways to diagnosis. So you might first have an ultrasound that gives some indication of whether or not there might be an endometrial cancer, but it's not diagnostic, meaning it can't say yes or no for sure. There's also an endometrial biopsy, which takes tissue from the inside of the uterus, and that would confirm whether or not there's an endometrial cancer in most cases. In the case that it's not confirmatory, or sometimes immediately after bleeding, you can also have a dilation and curettage, or a DNC, which is done in an operating room, where more tissue is taken from the inside of the uterus to determine whether or not there's an endometrial cancer. So right now, there are a lot of different pathways to diagnosis. Women might get an ultrasound first, they might get a biopsy first, they might get both. And because of that, there's a lot of variation in what's happening when women present. One area of early research that I reported on a few years ago with our team is that Black women, unfortunately, are less likely to receive the appropriate diagnostic procedures, so those that I just showed, to confirm an endometrial cancer. So we looked at data from Black women from the states that you see highlighted there, which are our cancer registry, and linked it to their health insurance claims. So these are women who were insured, and so we could see the billing claims and what procedures they had and did not have. And unfortunately, what we found is that Black women were less likely to receive the kind of guideline concordant or suggested procedures like an ultrasound, a biopsy, or a DNC when presenting with bleeding for endometrial cancer compared to white women. This is really important because not receiving these procedures, not being in the guideline concordant pathway was actually associated with more advanced stage at diagnosis when women were eventually diagnosed. And so this is important for our community to know, because although Black women, we are at greatest risk for more aggressive types of endometrial cancer, in this study of national data, we actually found that we're less likely to have bleeding categorized appropriately as being postmenopausal, so not being period bleeding, but being postmenopausal and therefore needing to be evaluated, to have our bleeding documented, and to have appropriate diagnostic procedures. And these pathways were associated with advanced stage of diagnosis and represent a potential point of intervention, because this is a quality of care issue where if women are getting the appropriate procedures, we can do earlier and earlier diagnosis. The second aspect I want to talk about with early diagnosis is that adherence to these guidelines, which means whether or not we follow through, both from the provider level and the patient level, adherence to the guidelines might be influenced by this normalization of bleeding among Black women. And this is where I bring us back to the context of Black women's reproductive health. As Black women, we have higher rates of fibroids at younger ages. We have higher rates of irregular menstrual cycles, where abnormal bleeding and bleeding in between periods is very common among women. And so when that is the case, it can also be the case that bleeding that happens later in life, especially in the postmenopausal area or around the time of menopause, that can be construed as also normal, and therefore not causing alarm or not being worked up appropriately, because we have this normalization of essentially poor quality gynecologic experiences from earlier in life. So looking at that question, I'm going to present a little bit of data from an interview study we did that also was seeking to ask this question and understand what was happening with Black women before diagnosis. So the first study I showed is really a study of insurance claims and data, not really talking to women. And so when we saw this pattern that women weren't getting biopsies, that women with insurance, even though they were having routine doctor's visits for other things, were showing up at stage 3 or stage 4 endometrial cancer, it caused us to ask the question, well, what's happening before the diagnosis? How are Black women experiencing symptoms and healthcare interactions prior to their diagnosis and during the time of the diagnostic workup of endometrial cancer, in order to understand better how we can intervene and have more early detection? So I want to take a moment, and I know this is a bit of a busy slide, but to comment that we really tried to organize this interview and this study thinking about how we as people make decisions about healthcare. And so there are a lot of different frameworks for how you can organize these. But we thought about two ideas, which is one, this is called the health belief model, where we understand that what you believe about your susceptibility and risk of a certain symptom, the benefits of having procedures, potential barriers to being able to have procedures, and your own belief in being able to deal with any particular symptom, that influences actions and when we decide to go to the doctor, and then also the experiences that we have there. But then as well, among Black women, we have to think about some of these race-conscious contexts, which is that in our country, we have a minimization of the severity of ailments among Black women, and we have data from other areas where we know that Black women's pain is not taken as seriously in doctors' offices or in emergency rooms. We even know this at this point from Black children, but certainly there's this issue of whether or not women will be taken seriously when they're disclosing their symptoms. We obviously have the history among Black women of a lack of proper care for Black women in reproductive health care settings. We know there's a high hysterectomy rate among our population, which might also influence how we interpret symptoms. And simply that, you know, it can be a source of stress to access healthcare, especially reproductive oriented healthcare as a Black woman, when there's a lot of shame and stigma around that in our country. So we really thought about this context when asking women about their experiences with endometrial cancer. So our questions from this study were very open-ended. So with having said all that, with the context we were thinking about, they were very open-ended. Tell me about what menopause was like. Tell me about any vaginal bleeding or spotting. Tell me what happened to you. So really just trying to hear the stories of women as they came out from their own individual experiences. So what did we learn? Well, with regard to menopause, we learned that there was some confusion, I don't think is the right word, but there was kind of a lack of a clear definition of normal versus abnormal menopausal symptoms. And specifically this idea that we won't really talk about what's going on with bleeding and menopause. That's not just really something that we're going to be talking about among family and among friends. And also that because women would have a lot of either sisters or their mother or aunts that have had hysterectomies, there wasn't necessarily, again, this is not speaking for all Black women, I want to be really clear, this is women in our study, there was not necessarily an understanding of what normal menopause looked like within a given family because of hysterectomies that happened prior. And so I'm going to give a couple quotes just to have an explainer of some of these themes. So this one says, well, the thing is, Black women don't really talk so much about menopause. They talk more about hot flashes. I'm going through these hot flashes. I'm going through menopause, but they don't talk about the period thing, you know. In terms of postmenopausal bleeding, what we learned is that women, they knew that bleeding was happening. It wasn't that they did not know what was going on with their bodies, but their initial experience of that or understanding of that was that this was a resumption of menstruation. So, oh, my period is back, or menopause is just continuing, like I'm just not done with menopause anymore. And the strategy of dealing with this was simply endurance, which is that, you know, I can handle this. This is just a little bit of bleeding. And so these are a couple quotes. I thought the menopause was trying to finish because I didn't have a lot of pain. I figured if something was wrong, I would be hurting. And, you know, this is something that I would offer comes out of our really lack of public health awareness and education and campaigns specifically around endometrial cancer and symptoms. And then you see the second quote there. I was just surprised, not alarmed because it wasn't heavy at all, but it was there. It was nothing compared to what I'd been used to in my 20s. And so this is calling back to what I was speaking about, which is that if you're dealing with a lot of heavy cycles, a lot of fibroids and issues earlier in life, it might take a different threshold before you imagine that something might be wrong, like a cancer, when you have bleeding later. Many women were waiting until increased severity of their bleeding or the onset of pain or some particular waiting period as opposed to immediately presenting. So this was the example. One woman said that she just waited because it had been happening for a year. And also just this idea that, like, how do we know what this really is? She says, I know I wasn't crazy. You could easily talk yourself out of thinking something is wrong when it can be explained by gas or bloated, or you're going through menopause, or you have fibroids. And so then again, coming up with this, that there are a lot of other reasons why it could be bleeding. And so that means I'm not going to be running to the doctor right away. And the last theme I think is really important, especially in the context of everything we've talked about up until this point. The context that Black women have an outsized risk of mortality with endometrial cancer, that Black women do tend to get more aggressive kinds of endometrial cancer. What women told us is that there was really a lack of explicit discussion from their providers that cancer was a potential reason for their bleeding, and that this kind of resulted in this minimization of the importance of further workup. So for example, a woman going in and finally disclosing, yes, you know, I am actually having bleeding, like something's going on, and being told, you know, she said, I've been doing some spotting, and she hears, oh, that's just normal, that happens, right? Which is not really the case. Another example is even when we're getting ultrasounds and getting worked up, you know, this question of why the ultrasound is happening, what are the possibilities? Another woman said, well, she got the ultrasound and the results she heard was, oh, it looks like there's a heavy lining in your uterine walls. So I'm just going to send you to this doctor to have it checked out. Now, maybe that's an attempt to be reassuring, but again, when you're not clear that what's being what the concern is or why this thing needs to be checked out, or thick lining means that you have a very serious chance of having a cancer, it really can change how quickly you go to that follow-up appointment, whether you think it's important or not. Again, you might have had ultrasounds before because of fibroids. And so what we have really is this mismatch between the risk of a woman coming in and reporting bleeding and the reaction and the interaction with a healthcare provider that's really vague about what the possibilities are in terms of diagnosis. So in summary, Black women in our study, again, expressed multiple factors that could easily and understandably be associated with delay before even presenting with symptoms. And one is that the nature of their symptoms were not really seen as being new or bothersome or painful initially. So new bleeding was just interpreted in the context of old periods, right? And the threshold for something being bothersome or painful was higher. Also, we saw this misattribution of the symptoms. In other words, thinking that, oh, this is because of my fibroids or because of my irregular cycles. We also heard other things like, maybe this is because I never had children, or we actually heard the opposite. Maybe this is because I had many children. So a lot of interpretation of symptoms, not recognizing this could be a sign of endometrial cancer. And then the actual cue to action of going and disclosing symptoms was after a waiting period or symptoms getting worse, which we actually know on the oncologist side is unfortunately signs of cancer progression. And then finally, the fact that healthcare provider reaction was really not aligned with our patients' risk, especially again, as Black women with these symptoms. So again, as I said before, I really wanted to be able to show you some information and some data, not just to talk the statistics, but also to get into a little bit of what can be going on around this issue of early diagnosis and how women might be presenting later for reasons that I think are very understandable and frankly are part of gaps that we have in terms of public health messaging and focus on this cancer that really specifically and most aggressively impacts Black women. So I want to end the talk, however, with empowerment and identifying actions that we can take now to improve early detection among Black women with endometrial cancer. So one, keep doing the research. I'm a researcher, so I have to say that, right? We have many more questions to ask. We know what, for example, a lot of older Black women, they don't have a primary OBGYN anymore. So how are these symptoms being assessed by first-line providers, right? Providers who aren't necessarily OBGYNs, but might be the first person that women are disclosing to. How do fibroids influence whether or not a woman is diagnosed correctly? Because we heard from a lot of women that fibroids was the first working diagnosis before they really got confirmation that they actually had cancer. And then also from coming back to the lens of race and medicine and stress and health, we know that lifetime stress is very influential on many aspects of our body. And there's a lot of questions, I think, to be asked about the stress influence on the uterus in terms of risk of endometrial cancer. But we can also gather in community. And I'm really appreciative to Cher for allowing me to come and talk about endometrial cancer and about ECANA, the Endometrial Cancer Action Network for African Americans. And we're focused on community education and research for really specific reasons. This statement is on our website, but I'll just read the first line, which is that we are a group of women who've come together to create support, community, and empowerment for any African American woman or person affected by endometrial cancer. And so in that endeavor, we're new on the block, but we're very excited to be able to support women because we see that Black women really are at most risk here and really need support. So who we are is that we're very patient-centered. So this is a picture of our partial leadership group, of which includes myself, but also several Black women, Margie, Adrienne, and Martha Jean there, with endometrial cancer, as well as community partners. But we also are a group of researchers and clinicians and project staff working together to think about how we start to address some of the statistics and the problems that I presented earlier in the talk. So we have quite a few activities. Our website I'll talk about in a little bit, and as well as the Survivor Sanctuary. But thinking about, again, this awareness issue, there are videos on our site so that women can go and look and watch videos of other women talking about their experiences to really try to reduce the isolation. We have a peer education program I'll mention in just a moment, and then as well as our research partnerships. So yes, I think I have a few slides from our site here. I'm going to highlight a few because there is a lot of helpful information. So this is all very patient friendly, written with our patient leadership team about understanding endometrial cancer, stage and grade, treatment options. And I certainly encourage anybody who has questions after the webinar to be able to check it out, because there's just a massive amount of information on the website. There's Learn the Lingo, where that goes through a lot of the vocabulary that us as doctors, which I'm sorry I've already done during this talk, kind of spill out without thinking about whether or not it's understood, as well as articles about wellness and the videos I mentioned. And then we also do a lot of research partnership, and that is really because a lot of the statistics around Black women and endometrial cancer and the things that need to continue to happen, unfortunately, the answers to a lot of them right now are we don't know. We don't know why Black women seem to not potentially respond to chemotherapy in the same way. We don't know why Black women are getting more aggressive types of endometrial cancer, and these questions need answering, and we want to be able to advocate for these kinds of research questions to get funding so that we can improve these outcomes. So this is a picture of the broader group, including not just our leadership team, but several of our ambassadors that are around the country. I believe in 11 different states right now. Our peer education program is called Community Empowerment Partners. And this was a specific training we did, again, because I mentioned this issue of really a lack of awareness around symptoms and signs of endometrial cancer and menopause. What we wanted to do was create a program where women themselves, endometrial cancer survivors themselves, could go out in their own communities and talk about this in a structured way to begin to raise awareness and also really turn the tide of the silencing that we heard about the symptoms around endometrial cancer, around bleeding, so we get more women to the doctor sooner. So this happened last year in the states that are highlighted there, and we're working on our report out of this program because we're really hoping to scale it and continue this work as we go forward. Oh, these were more specific pictures from these kinds of sessions, and again, our evaluation was very positive, so we're hoping to scale. One of our ongoing program right now, after the SEPS program ended, we started this Survivor Sanctuary, and this is all about trying to build community and support also for Black women who are dealing with endometrial cancer diagnosis or survivors. So it started out as chair yoga, and it's really kind of expanded beyond that to a lot of different exciting topics that we have planned for the summer around survivorship, around symptoms, meditation, mindfulness, you have it. So there's more information on our website, but that's another way that we are actively trying to support Black women with endometrial cancer. And I'll just say that when you look at this kind of graph, and I think it could be very daunting when we think about these poor outcomes, but I also, I just want to highlight that what we do here at ECANA and what I will conclude with in terms of action steps that each Black woman can take are really very specifically chosen and designed around trying to change this graph and trying to change these statistics. So in doing so, community, education, and research all play a role. Community, we know that people with cancer who have strong social and peer support respond better to treatment, actually have better quality of life and longer survival. That's why the Survivor Sanctuary exists, and that's why we really want as much as we can to continue to build community around and for Black women with endometrial cancer. And I also commend the efforts of SHARE in the uterine cancer program and having a peer support group for women of African ancestry, all around trying to build this kind of community that makes a tangible difference in how women truly do with their treatment and outcomes. Education is so important for all the reasons that I focused on for this talk, that knowledge around these early symptoms of endometrial cancer, it's going to maximize the number of women who are able to experience an early diagnosis and the highest quality of care, because they know what care should look like and they're able to advocate for themselves. So we're very passionate about this education piece, because there are a lot of things that we can change, within the healthcare system once a woman is diagnosed, but we also have to really focus on getting women to care as soon as possible when they have these symptoms. And then finally, participating in research efforts ensures that research studies are really designed to improve the outcomes of all women, including Black women, which means that we focus research questions on the issues that really do affect Black women disproportionately. So we're making sure that our science is helping all of us move forward and beat this disease. So I'm going to conclude here with my last few slides, and then we can open up for questions. As I promised, I really wanted to think about and be able to offer action steps for Black women. I think it's very important for us to understand and know what the reality is, what the risks are, what the statistics are, and it's equally important to have in our armamentarium the steps that we can take in order to maximize our ability to survive and in order to improve the outcomes for our community. And so for women at risk, so pre-diagnosis or simply at risk, actively managing irregularities with your menstrual cycle. I offer that we really have to move to a place where our expectation is of normal, healthy menstrual cycles, and we do not accept irregular, painful, heavy cycles as a part of life, because this does lead to increased risk of endometrial cancer later in life. I also really want to offer a step of keeping a relationship with your OBGYN through menopause or a women's health specialist. So that does not mean that you're in the office all the time, but it does mean that in going through the transition, you have a touch point of an expert that can talk to you about what is normal, what is not normal in terms of bleeding and potentially other symptoms. So this is not something we're trying to all figure out on our own, especially and potentially in communities or social circles where we don't actually talk about these symptoms anyway. Maintaining a healthy body weight is helpful for a variety of health outcomes, so certainly not just endometrial cancer. And I really want to emphasize that I think that there is a lot of conversation around obesity and endometrial cancer, and certainly obesity is linked to a lot of different cancers because of a lot of different mechanisms. Maintaining a healthy body weight is helpful for your overall health, and it is also helpful as a prevention of endometrial cancer. However, for Black women of all sizes are at risk for endometrial cancer, and so it goes way beyond weight management, though that is a part of what we can do to take action on behalf of ourselves. And lastly, just being aware and seeking care, meaning if something is off, if the cycle really does change, especially for my women who are older, 40s, 50s, 60s, women who have stopped bleeding and you think you're done and then the bleeding comes back, that is an absolute sign to have a consultation. Does it mean you have endometrial cancer? No. In fact, for most women, it doesn't. You know, we think about 90% of women won't, but that 10% who will, it really makes a difference between life or death and being diagnosed early. In terms of somebody, if you're getting worked up for endometrial cancer, or you find out that you simply do have endometrial cancer, you have been diagnosed. We at ECANA and myself as a physician want you to know that you deserve excellent provider communication, which means that a provider who's listening to you, who trusts you and your experience, and who is willing to explain things until you understand. We have resources on our website that can help with that, but this is critical so that you understand your own journey through treatment. And it also ensures that you're getting high quality care because you can ask the questions that you need to ask. I also want to say that ensuring you have support, not just from your loved ones, but from a larger endometrial cancer community is important for the reasons I stated before. That kind of peer support can help get through toxicities, can help get through the difficulties of treatment, and is also really important for survivorship. Yes, I didn't realize I said this twice. So yeah, ensuring you have support from loved ones and a larger endometrial cancer community. Again, ECANA is here, SHARE is here. You know, I think that there are growing numbers of resources and places to connect. And I think that this is truly one of the most powerful things we can do, because in groups, in communities, there's lots of knowledge sharing, there's wisdom sharing, there's hope, and there is a lot of truly physical and mental health that comes out of seeing other women who have not just had the diagnosis, but also survived and thrived past the diagnosis when a woman is affected. Informing yourself, finally, so you can advocate for yourself. So on our website, and I have the link there, we have these forms called Know Before You Go. They are free and downloadable. And again, they were very carefully designed to be very patient friendly. And they are things that you can take directly to your doctor's office if you have abnormal bleeding, if you've been diagnosed and you're planning on talking about surgery, but that hasn't been scheduled, for chemotherapy or for radiation, to start to help bridge the gap between yourself and your physician about what's going to happen, so you understand what questions to ask and you have information in the right place. these were really designed to capture what best quality of care is, so you have that in front of you, but also to be able to be useful for you to keep track of information going forward during your treatment. So if you simply have abnormal bleeding and want to make sure that you have a full workup, or you have a diagnosis and you want to make sure that you're getting highest quality care, these are very helpful, and again, free and downloadable from our website. So I think what's really great about what's happening right now in endometrial cancer is that there is a lot more awareness. And so I just have a few examples here of, you know, in social media and in the lay press, where we're starting to get articles, and specifically articles in magazines and media outlets that target African-American Black women that are talking about endometrial cancer. And I think this is a wonderful development, and I hope it continues, because the more awareness and conversation we get around this in our communities, the more empowered we will be for early diagnosis, early detection, and ultimately prevention. So I just want to acknowledge several funding support, a very expansive team, certainly not just myself at all, with this work there, and also just the scholarship of the people who come before me, many of whom are Black women, not all, that really helps set the stage to understand endometrial cancer a little bit differently, and be able to use my, on a personal level, use my platform to do everything I can to help improve the lives of Black women with endometrial cancer. So with that, I will close and say thank you again very much for this invitation to be here. I truly appreciate being able to talk about about endometrial cancer among Black women. It's just a huge passion of mine, and I'm just very thankful and grateful to share for the platform. And I'm happy to take questions. Thank you.
Now let's start the Q&A. You can still submit questions in the question pane in the GoToWebinar control panel. We will try to get through all the submitted questions, but we may not be able to due to time constraints. So the first question is there any stage or grade of endometrial cancer that has a higher incidence of recurrence, and does it have a time frame of likelihood?
Okay, I'm gonna try to repeat to make sure I heard it correctly. Is there any stage or grade of endometrial cancer that has a higher rate of recurrence? And then what was the second part of the question, Nefertari?
And does it have a time frame of likelihood?
Of likelihood, yes. So that is a great question. So yes, the grade of endometrial cancer tends to give a sense of the risk of it coming back or recurring. And so endometrial cancers that are grade 3 especially they have the highest risk of recurrence. And the types of endometrial cancer that are grade 3 is you can have an endometrioid grade 3, but then the other non-endometrioid types of cancer, so those include things like serous, carcinosarcoma, or clear cell. Those kinds of endometrial cancers, they're all grade 3s, and they do have a higher rate of recurrence. When endometrial cancer recurs, it's certainly not a rule, but most likely when recurrence happens, it happens within the first 2 years after diagnosis. Again, we follow patients longer because recurrence can happen later, but oftentimes it is in the earlier period rather than the later period. There's not any one cutoff, like 8 years or 10 years, where the chance goes to 0. It just keeps getting less and less the farther and farther that you get out from an initial diagnosis.
The next question is, what are the symptoms of endometrial cancer? What are the treatments if diagnosed? And are there any tests to complete yearly as assessment?
Yes. So the symptoms of endometrial cancer, the most common symptom is abnormal vaginal bleeding, and I'll specify that because the median age, so most women average age of diagnosis of endometrial cancer is 62. So most women who are getting it are either close to menopause, in menopause, or past menopause. And so the symptom that shows up is bleeding, either after a woman has finished menopause, like she's been done for a couple of years and then she starts bleeding again, or much heavier irregular bleeding, going through menopause, as opposed to bleeding getting lighter and lighter and lighter. So it's like the opposite effect. For younger women who are diagnosed with endometrial cancer, the bleeding tends to come in the form of extraordinarily heavy periods, extraordinarily heavy cycles. So those are the symptoms. Now, women also have reported things like pelvic pain as a symptom of endometrial cancer, as well as bloating as a symptom of endometrial cancer, but bleeding tends to be one of the most common signs. And then the second part of the question, Nefertari, could you repeat that again?
Are there any tests to complete yearly as assessment?
Yes. So endometrial cancer is a little bit different than your cervix cancer or your mammogram, where we have screening tests, where we have tests basically where we want to test healthy people because we've realized that you can either catch a cancer before it happens, like in the case of cervix cancer, you can catch a precancerous lesion, or in the case of mammograms, you can catch a very early stage breast cancer before potentially you can even feel a lump or anything. So that's screening tests, and that's why those tests are every year. So far for endometrial cancer, we don't have a screening test. What we have is the fact that it tends to cause a symptom very early. Now, for some women who have that symptom, when they present early, they actually are diagnosed with a pre-form of endometrial cancer called complex hyperplasia. So it is pre-cancer, and so it does end up preventing them from having an endometrial cancer. I hope that research continues so that we get to a place where we have a screening test, which is something that you could do every year to prevent this. But right now, what we have is our own ability to detect symptoms and then present to the doctor.
Next question is, how does endometrial cancer affect other cancers for BRCA-positive patients? More prone to this cancer if you have breast, or are you more prone to this cancer if you've had breast or ovarian cancer?
Great, thank you so much. So there is some data that I believe it's BRCA2, so I apologize, I can't be specific, but I'm pretty sure it's that one, have a slightly increased risk of endometrial cancer compared to women in the general population. Overall, in general, the relationship that we've seen between breast and ovarian cancer being together, where women with breast cancer have higher risk of ovarian cancer and vice versa, we don't see that as much as endometrial cancer. The genetic syndrome that endometrial cancer is a part of is something called Lynch syndrome. And for women and for people who have that, the other cancers that are related are actually colon cancer and also some bladder cancers. And so sometimes what we'll see is if a woman has a genetic or a family predisposition to colon cancers, it can very much be that she has an increased risk of endometrial cancer because of this Lynch syndrome. And we actually have an article about Lynch syndrome on the ECANA website that you can check out if you want to read more about that.
Our next question is, what is the best way to dispel folklore and myths regarding cancer?
Woo! Okay, whoever asked that, that's a whole day long answer. So I think, this is what I think it's really recognizing that folklore and myths about cancer, it's all coming from the same place, which is that people want to survive, right? People, what everybody is looking for are answers to help them feel more safe and a way to move forward so they can maximize the chance that they either never get this cancer or that they live. And so what I do understand about the folklore and myths is that I think it's coming out of a place of protection, right? Trying to protect ourselves, trying to make sure that we make the right decisions. And specifically for Black women with regard to the healthcare system and history, it makes sense to be a little bit more potentially concerned or have a little skepticism around Western medicine and things just because of the history that we've had. But when I am dealing with a patient that's having a lot of resistance potentially to treatment because of myths or folklore, I try to come back to the fact that we both want the same thing. And I think that anybody speaking to a member of community, we want the same thing. We want to survive and we want to thrive. And what is the case is that a lot of these myths, they come from earlier times or old times before we had the kind of diagnosis and technology and things that we have now. And they're just simply like very outdated. And so I really try to approach it from a relationship standpoint where you're getting at what is the real goal here. And if the goal is survival or if the goal is truth and data and understanding, then we can have a conversation around what the data actually shows and how women are doing well. Ultimately, I think the biggest way that we combat myths is simply to show Black women with endometrial cancer who have survived, who have gone through treatment, who have done well, and who have been cured. I mean, I think really that's the most powerful communication we can have there. And I think as we get more and more information and public messaging, and frankly, there are more people who are willing to speak about their experiences, I think those things tend to take care of themselves, or I should say, it just becomes more powerful when there's more information out there as opposed to just the myths.
The next question is there a biomarker for endometrial cancer, and are there different mutations in the tumors of Black versus white or Latino women?
Yeah, that's a great question. So they're not biomarkers for endometrial cancer. Some women who have advanced endometrial cancer or more aggressive types, they can have an elevation in CA-125, which is similar to ovarian cancer. It's not all women at all, but sometimes that can be a blood test that we use for women who've already been diagnosed to follow their treatment. In terms of the question about differences in tumor, so that's again another big question right now. And so what we know is that when you look at the molecular level, there are differences in the genetic makeup of the tumor itself. So not the women and their ancestry, but the tumor itself. There are differences in the genetics of the tumor between the different kinds of endometrial cancers. And so that is something that we know, and that's actually, there's a lot of effort to try to use that to develop different therapies that are more effective for each different kind of endometrial cancer, looking at these molecular or genetic differences. Now, the reasons why the differences would then present by race is because Black women are more likely to get more of the aggressive kinds of endometrial cancers. So if you look at them as a whole, they're going to have different mutations or genetics of their cancers themselves because they're more likely to get these more aggressive types. What's not been found is any particular aspect of African ancestry or something like that that is specifically related to endometrial cancer. So the question of why the tumors are different and what is causing that is still a question and is still very much under investigation. I am actually not aware. I think this work is ongoing right now. I'm not aware that we've had yet a really great, large, robust study looking at Latina women and their endometrial cancer tumors and whether this same pattern of difference in the makeup of the tumor itself varies or not. So I think that might be ongoing because I know there's a lot of work here, but I'm not aware that that data is, that we know that for sure yet.
Okay, so another question, and which will probably be the last question, is will you always have a thickening of the uterus with endometrial cancer?
Oh, great question. So not always. So this is why ultrasound is only okay as a screening tool when somebody has symptoms, because there, especially for the more aggressive types of endometrial cancer, you can be bleeding. Your ultrasound can show that your lining is thin. And so that can be kind of false reassurance. But essentially, if you have bleeding, again, if there's no diagnosis of why you're bleeding, the procedures have to continue. There needs to be a biopsy or a DNC to be clear of why the bleeding is happening. So the thickening can be a sign that can help us say, ooh, we think there's something going on here. You need a biopsy. But it's not the only one. And I would just strongly encourage any woman listening, if you're having bleeding, really regardless of what the ultrasound says, there should be a diagnosis of what's causing that bleeding, as opposed to just assuming that it's fine. So that's the answer to that.
Well, I just want to thank you, Dr. Doll, for an informative program. And thanks to all of you for participating and submitting questions. Please take a moment to fill out the survey at the end of the webinar, and it may take a few minutes for the survey to download. Thank you.
All right. Thank you so much. It's been a pleasure. Take care.
Bye.